Okay, this is clinical history, and today's topic is ectopic pregnancy. The idea of this presentation is just to give you a good overview and a general outline on how to take a history and the basic management of ectopic pregnancy. So, first of all, when should we suspect this diagnosis? We should suspect this in every. What's really interesting with ectopic pregnancy is the broad spectrum that we see, ranging from very mild abdominal pain all the way up to collapse and shock, and ultimately can be fatal. Why do we get such a range? Well, this depends on the size of the fetus and whether it has ruptured or not. And with a ruptured ectopic pregnancy, you're going to be seeing the more extreme end of the spectrum. Symptoms usually occur after 6 weeks of pregnancy. So 6 over 40, remember 40 refers to the 40 weeks gestation of a normal pregnancy. So symptoms usually start around 6 weeks. Prior to 6 weeks, the fetus is usually too small to really be causing problems. Although you can get women who present with quite mild pain at that point in time, or sort of 5 weeks, 5.5 weeks pregnant. That does happen, but generally speaking, you're looking at later on in the pregnancy. And why do we get these symptoms? The symptoms are caused by pressure from the growing fetus in a narrow space, in a space where it's not meant to be growing. 90% of ectopic pregnancies occur in the fallopian tube. So if you imagine, as that fetus is getting bigger and bigger, the pressure is increasing in that fallopian tube. That's causing the pain, that can cause bleeding, and ultimately that can then rupture and cause the more serious symptoms. Now, what are some of the risk factors that we see in ectopic pregnancy? So, if the woman has a history of sexually transmitted infections, STIs, and or pelvic inflammatory disease, PID, what this does is it can cause adhesions, which is just the posh word for scarring of the fallopian tubes. And when you've got this scarring and this sort of thin narrowing and stickiness of the tubes, the pregnancy, the embryo and the fetus, as it passes through the tube, is more likely to get stuck and not reach its final destination in the uterus. For exactly the same reason, we see ectopic pregnancies being more common if the woman has a condition called endometriosis, or if she's had previous abdominal or pelvic surgery, because both of these things can lead to scar formation and adhesions. The progesterone-only pill is an interesting one. It's also known as the POP or POP or mini pill, and this increases the relative risk of an ectopic pregnancy. However, it reduces the absolute risk is actually low. So what does this mean? What it means is if you're taking a contraceptive pill, your chances of getting pregnant are lower than somebody who's not on any contraception at all. And if your chances of getting pregnant are lower, there's less pregnancies, therefore there's less ectopics overall. However, if the woman does become pregnant whilst taking the pill, she is more likely to get an ectopic than a woman who was on no contraception or an alternate form of contraception. So in other words, less likely to get pregnant overall, but if you do become pregnant, the risk of an ectopic is raised, which is why I say to women, if you do find out you're pregnant whilst taking this pill, it is important to see a doctor early on to establish where the pregnancy is and make sure it's not an ectopic. There's also an increased risk in women who've had a previous ectopic pregnancy, probably because there's some underlying risk factors like adhesions in the fallopian tube. And it's also more an increased risk in smokers. In terms of symptoms, the most typical symptom would be a lateralizing abdominal pain. So a pain in the lower abdomen, either on the left or right. Remember, lateral means to the sides. As opposed to a more middle suprapubic pain, which you might get in early pregnancy, which is a fairly common phenomenon. With the growing pregnancy, it's not unusual for women to complain of some crampy abdominal pain. But pain moving towards the left or the right and then becoming progressive, more severe, that would be more typical of an ectopic pregnancy. And typically you'll have a woman who hasn't had any bleeding for the past at least 4 to 6 weeks. But remember that if you ask a woman about when her last period was and she says it is now, she's on her period currently, remember that PV, vaginal bleeding, is a symptom of ectopic pregnancy. So don't take things at face value. If she says she's bleeding now, ask her if her period is irregular. When was her last period? Is this bleeding expected, unexpected? Is it different from usual? And dig a bit deeper because sometimes people assume something as a period that may actually be abnormal bleeding. And so those are sort of general symptoms. Now, if the ectopic actually ruptures, the woman may have additional symptoms. She may feel faint and lightheaded, and that will be because of the internal hemorrhaging from the rupture causing her blood pressure to fall, so causing hypotension. She may notice that her heart is racing, so she may notice tachycardia. This happens as a response to the low blood pressure. And an interesting one is she may complain of shoulder tip pain, and that's really a referred type of pain. The phrenic nerve, which can be irritated by internal bleeding in the abdomen, also supplies the tip of the shoulder. So if it gets irritated in the abdomen, you can also get shoulder tip pain. And then far end of the spectrum, a woman may be rushed into A&E, into the emergency department, with a collapse. And that would be because of hemorrhagic shock. So no, she's no longer compensating for this low blood pressure and internal bleeding. Okay. Now, one of the questions you want to ask them is, if they say, I am pregnant actually at the moment, you want to know, have they had a scan yet? If they've had an ultrasound scan showing and proving the pregnancy is within the womb, so an intrauterine pregnancy, you've effectively ruled out an ectopic pregnancy. If they have not had a scan yet, or if they have had a scan but it was too early to actually see the growing fetus, then ectopic pregnancy is still a potential diagnosis. And if they deny being pregnant, because it's really common that you say to a woman, any chance you might be pregnant, and they say no, again, don't take it at face value, dig a bit deeper. What makes you sure that you're not pregnant at the moment? And they may say, I'm on my period, and then you question about whether their periods are regular. Is this a normal period? Was it expected? If they say, oh no, because I'm taking contraception, you want to question whether that method has been used correctly, whether there have been any missed pills or any breakage of the condom. These kind of things you want to be asking about. And obviously, are they sexually active? Full stop is a very helpful question. If they say, I haven't had sex for a year, then again, you've ruled out ectopic pregnancy. So you need to dig a little deeper. Don't take things on face value. And as I said before, remember that PV, vaginal bleeding, is a symptom of ectopic pregnancy. So bear that in mind. And then you can ask about their past medical history, looking for risk factors. So have they had a history of ectopic? Subfertility, the reason I put that in there is the lady might not know that she has blocked fallopian tubes, for example, but she may know that she's struggling to get pregnant. She's been trying to conceive for a couple of years. That might suggest there's something underlying like endometriosis or fallopian tube dysfunction because of adhesions. So worth asking that question, or it might come up anyway in conversation when you're talking about any chance you might be pregnant. You know, these things might come out. So remember, subfertility is a risk factor because of the things that cause subfertility can also put you at risk of ectopic. And remember, sexually transmitted infections, STIs, PID, pelvic inflammatory disease, or previous pelvic surgery are the key ones to ask about. Okay, and when we're examining this lady, really you need to document that you've done a heart rate and blood pressure, because as we spoke about before, those are two of the features of examination findings that may help you differentiate between a lady who's acutely unwell and needs to be admitted to hospital urgently versus a lady who can be managed in a more sort of elective outpatient way. So must do our heart rate and blood pressure. Abdominal palpation, you can assess for guarding and rebound and just the severity and the location of the pain. And a good bedside test would be to do a urine for beta human chorionic gonadotrophin, or beta HCG, which to URI is the pregnancy test. Okay, so that's a really simple one you can do at the bedside, proving whether they're pregnant or not. And then management is obviously going to depend on a couple of things. First, it will depend on whether the woman is hemodynamically stable. And what do we mean by this? If you are hemodynamically stable, you will have a normal blood pressure and a normal pulse, suggesting that all is well in the world. If you're tachycardic with a low blood pressure, or either or, or the other way around, so if you've got a normal blood pressure but you're tachycardic, this can all be suggestive that the lady's not stable. If the patient's stable, then you can refer to the early pregnancy unit. What will they do there? They probably won't see her on the same day, they'll probably see her on the next day, and they'll do an ultrasound scan, and that will confirm whether it's an ectopic or an intrauterine pregnancy. If they can't do an ultrasound scan, or the ultrasound scan's not really conclusive because of the length of gestation, let's say she's 5 weeks pregnant or just turning 6 weeks pregnant, you can do something called serum beta-HCG, so serum as in blood version of the pregnancy test. And what this can tell you, if you on a normal pregnancy, the numbers go up exponentially. In an abnormal pregnancy, so in an ectopic or if they're miscarrying, the numbers go up at a slightly different rate. So it can give you a kind of guesstimate as to whether an ectopic pregnancy is likely or not. And if the patient's unstable, if you're in primary care, that patient needs to be referred urgently to the gynaecologist. If you're in A&E already, obviously, again, you need to urgently refer to a gynaecologist. But in the meanwhile, you can do some very sensible, helpful things like making sure you've got access by putting cannulas in, cross-matching some blood, administering fluids, etc. And in terms of the definitive treatment, that will be either medical or surgical. The medical treatment can be with methotrexate, and that's particularly a possibility if it's an early ectopic and the patient is stable. Otherwise, the treatment is surgical, and that's usually through a laparoscopic salpingectomy. Salpinge means fallopian. Ectomy means to make a cut, so to cut out part of the fallopian tube. Sometimes they can do a salpingotomy, which is just to make sort of a mouth-like hole and try and remove the ectopic pregnancy that way. Unfortunately, any surgery to the fallopian tube does mean it's probably not going to be functional in the future, or certainly will be less functional. And if they do something like a salpingotomy, you know, you've got that risk of future ectopic, which we know is there anyway. So this is a really serious problem for women who are wanting to get pregnant, because they may well lose entirely or lose function of one of their fallopian tubes, and they're at greater risk of this happening again. So not something to be taken lightly, really. So that's just a whistle-stop tour of ectopic pregnancy. I hope it's been helpful and just given you a really good overview and grounding on the topic, so that you will remember the key things. I've not gone into loads of detail about some of the topic, but the key features that will really help you to clinically manage a patient in this context.